Dr. Nav Persaud is the Canada Research Chair in Health Justice and Associate Professor at the University of Toronto and a staff physician at St. Michael's Hospital in Unity Health Toronto. He is leading the first ever trial providing people with free access to essential medicines, quantifying the links between medication cost and health outcomes, and bringing to light the unfair choices that millions of Canadians are forced to make about their health. His interests include health equity, essential medicines, clinical trials, and racism in healthcare settings. I had the pleasure of spending a few days with Nav a few years ago when he came to present for us, and he's a lovely person and an extremely bright a researcher and clinician, and I'm sure you'll enjoy his presentation. Thanks, Nav.
Thank you, Aaron, for that really kind introduction, and thank you again for allowing me to participate in a therapeutics initiative session. I'm really looking forward to the discussion with all of you. Thanks for tuning in today. These are my disclosures. I receive research funding mostly from public sources related to the Government of Canada, and the Government of Ontario additionally receives some travel expenses paid for by the Public Health Agency of Canada for my work as a member of the Canadian Task Force on Preventative Healthcare. The objectives today are to have you learn about essential medicines list and mostly how you might develop a list of your own and find out about what's being done by others, including those in other countries. I'll also be talking about the results of the trial that Aaron mentioned in the introduction. But before that, I wanted to tell you a little bit about how I got interested in essential medicines that I'll help define in a few minutes. When I was a resident, I was exposed to some pretty surprising decisions that some of the medical students I was helping to supervise were making when it came to prescribing opioids. And when I asked them to explain some of the decisions, like one example was prescribing Percocet, that's a combination pill that includes both acetaminophen and oxycodone, to a patient who was admitted with an acetaminophen overdose. I was surprised by what came back, and I was shown the notes that the medical students had received during their lectures on pain management. And I realized that there were a number of falsehoods in those notes. And also, somewhat alarmingly, I realized that they were more or less the same notes that I had received when I was a medical student. So over the course of several years, and this is starting around 10 years ago, I raised concerns about what medical students at the University of Toronto were being taught about pain, and eventually found out that the course that they were that we all were attending was supported and funded by Purdue Pharma and outside individuals who are not associated with the University of Toronto were being brought in to provide us with these lectures. At that time, it was heresy. It was very controversial to question the prescribing of opioids. And I think it is quite different today. Today, even a character played by Michael Keaton could get into trouble when prescribing opioids. And there's, I think, general recognition of the problems and of the opioid crisis being experienced primarily here in Canada and in the United States. But that was one of my first initiations into how things can go wrong when medications are not prescribed appropriately. Later, I was caring for a patient, and she had nausea during pregnancy, and I prescribed Diclectin, which was, as I understood it, the first line agent for nausea and vomiting during pregnancy. And this patient had questions, and I reassured this patient that this is what everyone was receiving in the similar situation. And when I was doing my training, actually there was a prescription pad that we just had to write the duration of treatment for Diclectin, and that was provided by Duchenne, the company that makes it. And in the obstetrician's office, it was just a matter of more or less filling out a number, signing that prescription, and handing it to patients, and they would go home and swallow these diclectin pills. When I looked at what was behind these like grade 1 recommendations for diclectin as used for nausea and vomiting of pregnancy, I realized that one of the clinical practice guidelines in a national journal in Canada cited not a systematic review or even a clinical trial showing that the medication was effective, but rather the product monographs document created by the drug company that sells the medication. And ended up over the course of many years trying to obtain all of the information about the clinical trials and other studies done to measure the effects of diclectin or doxylamine and pyridoxine for nausea and vomiting during pregnancy, and concluded that the medication isn't effective. It doesn't work at all. My practice is in downtown Toronto. It's a diverse patient population. And it includes people who can't afford medication. So these would be individuals with a relatively low income who don't have private insurance through their employer, like around 55% of Canadians do. And so sometimes life-saving treatments like insulin or relatively inexpensive treatments for cardiovascular disease are out of reach for these patients because of the cost. So it was really these three factors together that led me towards learning about Essential Medicines List. And, we had decided as a group of clinicians that we were going to try to keep on hand some medications that we could give out to our patients who had trouble affording medications. And we looked at some of the drug samples that we had, and they were in some cases, samples for medications that we would never prescribe, like oral contraceptive pills that carried higher risks of blood clots than other pills and no benefit. So we decided that, because I was the researcher in the group, I would look into which medications we should stock. And it seemed like a daunting task. And it was only at that point, though, that I realized there was this wide body of research on essential medicines lists that had been around for a long time, more than 40 years now. In 1977, the World Health Organization released its first model list of essential medicines. And there's not a really long philosophical discussion about what it means for a medicine to be essential. The definition is very simple. It means that the medication is needed. In practice, that would mean that the medication is highly effective, and that the effects of the medication, including the potential harms, have been characterized to an extent that it would make sense to take the medication and prescribe it based on its known benefits. Another way to think about it in practice is if you were going to be the family doctor on a new space station or new colony on a different planet, which medications would you take with you? On the one hand, you wouldn't want to leave behind any highly effective medications that people would need that are essential. On the other hand, you wouldn't want to take with you 5 or 6 different medications that did the same thing, because that would just increase the weight in the spaceship and would not serve any purpose. So you'd have to create a list of essential medicines. So let's return now to this planet for a little while and think about this country, Canada, and how an essential medicines list might work here. Canada is the only high-income country on this planet where healthcare services are publicly funded, but medications are generally not. So I was mentioning before, some people have private insurance, mostly through their employer. Others have public insurance. Those would include social assistance recipients, and in some jurisdictions, older adults have public coverage. But that would leave a large number of people who can't afford medications. And current estimates would be that number would be around between 1 and 2 million people who would report not taking a medication because of the cost within the last year. So, pharmacare or publicly funding medications, including medications in our publicly funded system, including medicines like a list of essential medicines, could allow Canada really to leapfrog ahead of other countries where we're behind, like more or less every high-income country with publicly funded healthcare services right now, where we could ensure equitable access and also the appropriate use of medications throughout the country. So, after going through this exercise at a local level, my colleagues and I realized that there was a bigger national issue that we could maybe wade into. And so we decided to do a clinical trial of providing people who reported cost-related non-adherence or the inability to take a medication due to the cost with access to medicines on an essential medicines list. And this is the process we went through to develop the list of essential medicines. We started with the WHO's model list, and the model list, it was started in 1977, but it's been updated every 2 years since then. We added some medicines based on clinical practice guidelines in Canada. For example, we added a bisphosphonate medication that was not on for the treatments of for the prevention of fragility fractures. There were no such medications on the WHO's list at the time. We sought feedback from clinicians in a number of disciplines, including primary care providers, respirologists, cardiologists, endocrinologists, pharmacists. We reviewed national prescribing data and also provincial prescribing data in Ontario to determine whether or not there were any frequently prescribed medications that were not on our list. And we had a group of a panel that would have at least 3 clinician scientists on it at each time, review all of the evidence that was summarized after a search by a librarian, and then make a decision about whether or not medications should be added to the list, removed, or if there should be a substitution. And through that process, we came up with a list of, depending on how you define a medicine and how you treat combination products, of around 130 or 140 medicines. And if you want to browse the list another time, they're available, at our study website, and I'll be sharing these resources and the URLs. So these medications, they're meant for a primary care setting, an outpatient setting. Some people are surprised by some of the medications that are on the list and off the list, and be happy during the discussion part to explain some of the decisions that we made. But just to give a few examples, for thinking about some of the commonly prescribed medications for gastrointestinal complaints, these would be the 2. So we don't include every proton pump inhibitor. We include pantoprazole for a number of reasons, including the fact that it is less likely to interact with antiplatelet agents. In the area of cardiovascular disease, I think, these would be some of the standard commonly prescribed medications across Canada based on our review of prescribing data. Pain medications, also, these would be very commonly prescribed medications. You'll note that not all of the NSAIDs that you're aware of are there. For example, diclofenac is a fairly commonly prescribed medications. There are a number of studies, observational studies, that indicate, compared with naproxen and ibuprofen, diclofenac has a higher risk of cardiovascular disease and no known benefit in terms of its efficacy over ibuprofen or naproxen. When we look at the short list of medications, like around 130 medications, and we consider equivalency across classes, then it would seem that depending on how you define things, this relatively short list of medications would cover like around 80 to 90% of the prescriptions written across Canada. So after developing the list, and the purpose of developing the list was mainly to do this trial. So we recruited from a number of primary care practices in Ontario, including several in rural parts of Ontario, so not just in Toronto, 786 people who reported cost-related non-adherence, not taking a medication because of the cost in the last 12 months. And we randomly allocated them to either free access it to this list of essential medicines that were, in most cases, mailed to people if they were long-term treatments, but for medications that needed to be started in a timely fashion, like antibiotics, those were dispensed in the clinic before people left. And then in the control group, people continued to have their usual access to medicine, so which would be, could have been paying out of pocket, could also have been, in some cases, accessing it through private insurance. And sometimes people couldn't afford to take medications because they couldn't afford either the copayment or the initial payment that would later be reimbursed. And we have a small number of people who actually did have public coverage also. And similarly, there were some fees that restricted access for these individuals, although they had coverage. And then we measured outcomes like adherence, healthcare related expenditures, and well-being. And in a nutshell, the findings were that adherence to medicines that were appropriately prescribed increased. So there's absolute increase in the rate of taking medications as instructed by just over 10%. The biggest improvement that we saw in this study, though, wasn't one that was directly related to health. It was a large absolute increase, so almost 60% absolute increase in the ability to make ends meet or afford basic necessities like food and rent without incurring debt. So, you know, the rate of the inability to make ends meet was around 25% in the control group, and it was around 80% in the group who got free access to medicine. So eliminating even modest medication costs for some individuals would be the difference between being able to pay the rent on time without incurring debt or not. From a systems or governmental perspective, there was a substantial savings in terms of healthcare spending. So a median savings of $1,000 over the study period of 2 years, or you know, a mean savings of around $2,400, and that was mostly related to costs associated with hospitalization, including emergency room visits and intensive care unit admissions. And you know, some people question whether or not providing access to these medications could itself like really have these impacts on healthcare utilization and hospitalizations. And just keep in mind, you know, that for the most part, we're talking about medications that have been well studied and are known to be life-saving. And one example would be insulin, that was discovered almost 100 years ago and remains, despite that, a very expensive medications, although the rights to insulin were sold for $1 each for that went to the co-discoverers. So, you know, in many ways, it was a very simple project. And like when I tell my, you know, family members and friends about this project, they say, oh, like you went to university for all those years to learn to do a study of providing people with medications that we know work already. Like that is the main finding here, that effective medications make people healthier. And that is, it is that simple. But the reality is cost-related non-adherence is still common in Canada, and that burden is not equally felt, right? So we know that racialized people, for example, are more likely to experience cost-related non-adherence than others because of sexism in the workplace. Women also experience cost-related non-adherence differently from men. So, you know, I think there is still this remains a really important issue, although to many the answer would be obvious. Now, if we ignore the savings related to avoided hospitalizations and avoided healthcare expenditures, et cetera, and we focus just on medication costs, this work led by Professor Steve Morgan, who you're going to be hearing more from in a future session, showed that if we saw in Canada costs seen in other countries like New Zealand for medications, there would be a savings of around $3 billion per year. And that would involve, just to be clear, an increased public expenditure of around $1 billion across Canada. And the savings would come from spending about $4 billion less in out-of-pocket charges and amounts paid by insurance companies who tend to actually prefer higher drug prices because they take, in most cases, a percentage of each claim. You know, I don't actually, I think in my view, these are like relatively conservative estimates that over the years, you know, and this issue of pharmacare and including medicines in our publicly funded system, it's been recommended multiple times over the last 50 years. And many times economic analyses like these have been done, and they have shown that we are going to be saving lots of money if we include medicines in our publicly funded system, but they have never been persuasive. These arguments, that they have never prevailed today. So, you know, we wanted to fill out the story, and we did some qualitative work where we had people in both groups, the group who got free access to medicines and those who did not, share their experiences. There were the benefits of getting free access to medicines were manifold. You know, people talked about less stress and a greater ability to afford other necessities like food for their children. They talked about a number of ways in which their life was less stressful. They also talked about how their relationship with their prescribers improved, because this dynamic would get set up where a doctor would prescribe a medication, the patient maybe would fill it once and not be able to afford to fill it, or they would never fill it. And then they develop this anxiety about going back to their doctor and, you know, having them check their blood pressure and see that it's still high. And so they talked about how their relationship with their physician improved when their access to medicines did, even though there's no real direct reason for that to happen. And of course, throughout this period, the participants would have had access to publicly funded healthcare services, including going to see their family doctor. So that didn't change between the intervention group and the control group. You know, it was interesting among rural participants how the issues are somewhat different. For some individuals who are growing most of their food, medications might be their biggest monthly expense, or their second biggest, next to heating costs. So, you know, eliminating those medication costs or even reducing them can make a big difference. And for one individual who shared a story on a video on our study website that you're welcome to review, you know, he talked about being able to work his land better when he had access to his puffers. This work led into some other work that we have done in trying to inform public policy changes in Canada, like at various provincial levels and at the federal levels. Been in discussions with decision makers about which medicines should be publicly funded here. And there is some movement right now towards potentially creating something that could later form a national formulary, and that work is being headed by Qualitative. It was, as I understand, suspended around the last federal election. But one of the common questions that we got back from decision makers was, well, which medicines are essential? Like which medicines are essential in other countries that have an essential medicines list, and, you know, which would we consider essential in Canada? And I was a bit surprised to learn that no one had really answered that question. So over the course of several years, my colleagues and I created a database that now lists around 140 essential medicines lists, national essential medicines lists that have been created by low, middle, and high income countries. And so, if you like and you're interested in which medications are covered in many countries, which are included by only a few, you can browse that website. The database is also available for you to do analyses that you think are interesting. We thought about a few things that we thought would be fun and potentially useful. So, we've tried to correlate health outcomes, like at the top graph, we're looking at avoidable mortality related to cardiovascular disease. And then, we plot that against medications that are essential cardiovascular disease medications as defined by the WHO and based on other international guidance. We've also, in the bottom left, looked at antibiotics and tried to identify potential changes countries could make to their lists to, at the same time, ensure that highly effective treatments for relatively common and deadly infections like meningitis are actually present in countries, and at the same time promote antibiotic stewardship and avoid antimicrobial resistance by prioritizing access to certain medications, again, based on guidance from the WHO. That's also elaborated on at the essentialmeds.org website, which is now actually co-hosted by the WHO and by our research group. We've also created maps, like in the bottom right, both globally and also maps that focus on regions. And we have created tailored reports for some countries that compare their essential medicines lists to peers in the same region and the same income band or GDP band to help them identify potential improvements to their list. And although overall, I think there are a lot of success stories in these lists, and in many cases, the medications included in these lists are obvious and highly effective medications, there definitely are some problematic medicines that continue to be included in national essential medicines lists. Rosiglitazone is an example of one that had a high profile, notoriously related to excess cardiovascular mortality. Similarly, cisapride was a medication that was used for various gastrointestinal complaints, and it causes arrhythmias, and was eventually withdrawn from the market in Canada and in other countries. And yet, up until today, more than a handful of countries still included in their national essential medicines list. And in some countries, the national essential medicines list would determine which medicines are publicly funded, which are available in healthcare institutions, and which medicines, for example, pharmacies are supposed to be able to demonstrate they have in stock if they are audited. Phenobarbital is a treatment for asthma that doesn't have any benefits over salbutamol. That's the more commonly used medication. And phenobarbital is actually more expensive than salbutamol. Phenobarbital is also associated with excess cardiovascular mortality without any benefit over less expensive and equally effective agents like salbutamol. So there's work to be done in improving national essential medicines lists. And to bring this back to the individual level, I think there are a couple of reasons for you, in the absence of a national essential medicines list now, to think about maybe creating your own for your own use. So there are a few studies that indicate that you're more likely to appropriately prescribe a medication if it's from a short list, like an essential medicines list. And one of the studies actually came from the development of a shared list. So what they found, and this was studied in England, where they were developing like a short formulary, something like a national essential medicines list. And they want, and it was just to be used as a guide by other clinicians. And what they found was after they developed this list and released it into like general use by a group of providers, a group of primary care providers, they couldn't detect any long-term impact on prescribing, on appropriateness, and they were also looking at whether or not prescribing was cost-effective. So no long-term impact. There might have been like a brief positive impact when the list was first disseminated, but what they did find, somewhat surprisingly, and I don't think this was the focus of the work or the intent, was that those who were involved in developing the list actually did seem to have experienced a sustained and substantial benefit in terms of the likelihood that they would prescribe medications appropriately, or alternatively, a decreased likelihood that they would write prescriptions that were potentially inappropriate. One of the clear findings from surveys and other studies of trainees and clinicians is concern around the volume of information that needs to be learned, and including the volume of new information that might be available each month or year, and whether or not that it's true that there is a large body of information that we actually need to digest. Certainly that is a concern, and focusing on a short list can reduce the amount of information you need to digest, and certainly reduce the amount of information you need to remember when it comes to things like starting doses and interactions, which if you make a list and write it down yourself, you actually may not need to look at it again, similar to, as I find, like if I write down a shopping list, then I actually don't need to refer to it. But if I get lazy and don't write down the list, then I get to the supermarket and I'm struggling to remember what I have to get. And then, if you have that list, when you're confronted with something new, like an ad or a talk, or you see a colleague, a specialist prescribes a medication that you never heard of, you can really focus your learning on whether or not that agent is really needed, whether it's better than a medication that you already have on your list. And I think that's really a healthy exercise. It'll force you to look again at one or two of the choices that you made before, and then you can continuously update it and stay current with the literature. Maybe it's going to seem like I'm a bit desperate to convince you here when I describe creating this list as fun. But I actually like this idea about the colony on a new planet. And, to some extent, if you are traveling, like if you are, the physician for a sports team, you do have to make some of these decisions. And, applying that thinking to your entire practice, I think can be an interesting exercise, regardless of, whether what other people might think about it. And I think it's actually easy to create an essential medicines list for yourself. The first step is, I think it could be difficult just off the top of your head try and think of like all of the most important medications to prescribe. It's difficult to generate all of that. So to make things a bit easier, you probably want to start with an existing list. And on the next slide, I'm going to show you some resources for them. And then, after that, and when you look at that list, you're probably going to want to make some additions or subtractions just right off the bat. And then after that, if you use the list and revise it as you need to, you add to it when you encounter in clinical practice a situation where you really need a medication that's not from that list. Similarly, if you come to believe that a medication on the list is not as effective as you had originally thought, then you might take it off. And then it can also be fun and interesting to share and compare with colleagues, and can be a way for each of you to learn. So obviously the list that we created, for our purposes here in primary care in Ontario, just as, not on a province-wide level, but just, like us researchers and clinicians in Ontario who were part of the Clean Med study. That's a potential starting point at our website. If you have a favorite country out there that's not Canada for some reason, you could go to the website essentialmeds.org and see what the essential medicines list for those other countries are. Obviously, in some cases, there are going to be treatments for conditions that we don't commonly encounter in Canada. But the reality is there's actually quite a small number of treatments that would be for conditions that we don't see here at all. And most of the medications used across the world are the same, treatments for high blood pressure, diabetes, asthma. There aren't important differences across countries in those. The WHO has its model list that is the basis for most of the national lists. So you can find that on the WHO website, by doing a web search for WHO and essential medicines list. And then there's the Swedish WISE list also. For whatever reason, people seem not to like using lists made in low and middle income countries, although, to my eye, many of those lists are excellent, including the list from South Africa. And I think for whatever reason, people prefer to use lists created in high income countries, including in European countries. There are several. And, one of the lists that's easily available in English is the Swedish WISE list. And that list has been developed over a number of years, and they've gone through a number of iterations of I think trying to increase the confidence of both the public and clinicians in the list. And I think they've done a good job. They had ads on the sides of buses at one point. And now I understand it's the case that in some patients, will ask a clinician, is this medication on the WISE list before they go and fill the prescription. So hopefully we have at least touched upon some of these objectives where you might be able to, if you chose to, select a short list of medicines for your own use in clinical practice. We mentioned some of the resources about essential medicines list, and we talked about some of the effects of providing people with free access to essential medicines as found in the Clean Meds trial. At least, obviously work like this is done by a large number of individuals, and I've provided some references throughout, and obviously the co-authors of all of those papers have played in many cases an even more important role than I have. And I'm also grateful for funding and support from these organizations. Of course, I'm really grateful for the invitation to speak to all of you today, and I'm very much looking forward to the discussion.
Thank you so much, Nav. As you can imagine, after listening to him speak, Tom Perry and I were trying to recruit Nav to BC. We even bribed him with a legendary burger and fries on BC ferries, and it sadly didn't work. But we will continue to try to get him here somehow. Really bad jokes aside, Nav, thank you so much for the great presentation. You've just reinvigorated my interest in this topic after I heard you speak the first time while eating that free burger, I might add. So let's just get to the questions. What actionable strategies do you recommend that healthcare providers can do now to support patients facing cost-related non-adherence? And can provincial drug plans be leveraged to fill this gap while we await national pharmacare?
Great question. And, in many ways, like the most important issue is, what do we do for people who can't afford to take life-saving treatments right now? One thing is, scramble. So do everything you can to try and get that individual patient access. We do fundraising. We have what we call a comfort fund to pay for medications. We have programs where even like clinicians and members of the team pay for medications. So that's one part of it. You can try and secure drug supplies from other sources. I think there's some potential pitfalls there, but sometimes these pharmaceutical company-run programs are appropriate and helpful, at least for the period of time when the patient can get access. I think there are a fair number of patients who have cost-related non-adherence who actually are eligible for governmental or non-governmental supports, but for whatever reason, they have been reluctant to apply. Could be because they didn't file their taxes, or it could just be they were intimidated by the form. So I think you should always consider that, and hopefully you practice in a place where there's some support and people who know about all of the forms and know about all of the governmental and non-governmental programs, even though it's going to be a small number of a small percentage of patients who will benefit. So that's one, is scramble and do whatever you can for the individual patient. I think if you do that for a long time, it can take up a lot of time and energy. And so I think it is important in the long run to put ideally at least an equal amount of time and effort into advocacy and trying to change things, because people have been working on this for a long time. Like Professor Morgan, you may mention to you that it seemed like in the 1990s that medications were going to be included in our publicly funded system, but that hasn't happened. And as clinicians, I think we've become too docile and accepting of this state of affairs, where people come to us, there's a life-saving treatment they need, we prescribe it, they can't afford it, they have a heart attack, a stroke, or they die, and we just shrug our shoulders and say, that's the way the world is. And I think we need to stop doing that and advocate. And well, I'll just briefly mention, we've talked about some fairly extreme measures here, and we actually published a paper in the Canadian Family Physician about administratively admitting people to the hospital, even though they wouldn't ever set foot in the hospital, they would receive publicly funded access to medicines through the hospital's pharmacy, because medicines for inpatients are publicly funded. So I would encourage you to think about direct action like that can provide people with access to medicines. And I'm happy to speak to you offline about that.
Thanks, Nav.
Yeah.
Just another question. In the process for developing the clean meds list, you talked about clinician scientists and others on the panel. Were patients ever part of that panel, or did you consider patient values or input in that process?
Yes, excellent question. So I didn't describe like every facet of the clean meds trial, but it was based on some preparatory work done by a community guidance panel, who recruited in part by canvassing this part of Toronto to make sure that we included people who experiences the disadvantages we're trying to address. And they were involved in the design of every aspect of the project, including the outcomes, and yes, the intervention and the list. So we had a number of extensive discussions with the community guidance panel members and others about how the list should be formed. And their advice was clear that patients should have the ability to suggest changes to the list, and members of the public should have the ability to suggest changes to the list. But the community guidance panel members felt that that it would be better for the decisions ultimately to be made by clinician scientists. So that is the process that we went through. However, the criteria that were used to determine which medications were listed and which were not, those were also co-designed by the community guidance panel.
Okay, great. Just to give you a chance to catch your breath and take a sip of water, if I could remind people that you'll be receiving an evaluation form, and regardless of the need for continuing education credits or not, we value your input on the success of the webinar and ways in which we can improve. So we'd really appreciate you taking the time to complete the evaluations. And if you do and would like the continuing education certificate, after you send in the form, we'll be mailing you a certificate with the credits. So just a reminder for that. Nav, on to the next question. You mentioned a number of other countries that have essential medicines lists. are they an academic exercise, or do they actually, in some cases, do they use them to provide free access to medications?
It varies between countries, but in many countries, it's extremely important. So they would determine, these lists would determine which medicines are publicly funded and which medicines healthcare institutions like hospitals and pharmacies are obligated to stock. So in many countries, basically the National Essential Medicines List would determine in practice which medications people take and which ones they don't. Even though, like in principle, clinicians and patients may be able to decide, and in practice, they would actually be determinative.
Okay. Just a question for me. Do you, in your prescribing, when you see patients, use your own essential medicines list?
Yeah, that's right. Yeah, so I had some of my own patients who were participants in the Clean Med study, and so I obviously got familiar with the list through directing the project. So yes, over time I have come to prescribe medications primarily from the list. Initially, it was only for patients who were in the study, and that where I would switch them from other ACE inhibitors to ramipril. Then it became, then when a patient was starting a new medication, I would principally or solely start new medications from the list. But then I had a number of patients, obviously, who were already taking other medications that were not on the list. And over the years, I have slowly been changing people over to medications on the list.
Interesting. Are you aware of work that's been done with the community-based essential medicines list versus hospital formulary list? Because participants noting that sometimes hospital formularies are more concise. They have space restrictions and contract pricing issues. Any work in that area?
Yeah, yeah. So, I mean, there's surprisingly a lot of resistance to these short lists or short formularies in Canada for outpatient uses, even though they are very commonly used in the hospital. And like at my hospital here, any patient who's on a PPI before admission is switched to pantoprazole when they're in the hospital. It doesn't matter what the physician who's admitting the patient writes on the order form. They can write any proton pump inhibitor they want, and the patient's going to get pantoprazole. So those sorts of changes are routine and commonplace in hospitals in Canada, but they're less commonly used in outpatient settings. But the same sort of thing actually happens in the NHS and their local formularies. So similarly, you can write any ACE inhibitor you want on a prescription as a primary care provider, but the patient's not going to get it. They're only going to get the one that's in the local formulary. So, I think it would make a lot of sense, if we had a national list or at least provincial lists where we could align practices between hospitals and outpatient settings.
Okay, great. Just a reminder to everyone to make sure you mute your video and your audio for the duration of the webinar. Another participant has said it's an interesting concept of what should be essential and what should make it on the list. So they had questioned the addition of donepezil and also questioned the absence of the SGLT2 inhibitors for diabetes or heart failure. And so what's the process for updating the list?
Yeah, I think if we were making the list today, it's likely that some of the newer, or at least one of the newer treatments for diabetes would be on the list. So basically what happened when we were conducting the study is that we didn't have one of the newer treatments for diabetes on the list, and we had a number of suggestions. The panel, I believe 2 or 3 times reviewed the evidence and came close to adding medications like empagliflozin to the list, but decided not to. I think, if the list were going to be used more widely, you'd have to balance like strictness and rigor with acceptability and ensure that the list is acceptable both to clinicians and to patients. And I think there would be a good case to be made for updating the list and adding certain medications. We haven't had a reason, because the study is to a large extent wrapped up now, to make recent changes to the list. Another change was, the suggestion to add a number of antidepressants. Those came to the committee probably 5 or 6 different times. And usually the committee found that there weren't, based on the literature, important enough differences between different antidepressants to add an additional one, because several are already on the list. But that would be another area, I think, where you'd want to balance rigor with acceptability.
Okay, Nav. Another audience member is asking, presume that the data you have are shown as part of the argument for federally funded pharmacare. So do you have the ear of the federal government?
I wouldn't presume to have the ear of anyone, but we definitely, they definitely get messages from me in communications, and there are some discussions going on about at the federal level, at least about creating a national formulary. So yes, we are really active in advocating and have some other plans, like including related to the one I mentioned before around administrative admissions to the hospital, to really try and precipitate policy change here.
Okay. Essential medicines list in developing countries is useful to encourage the government to make available a minimum range of drugs to people. And it brings up the issue of free access versus actual access. In Canada, we can buy everything. Is then an essential list the answer? It's hard enough maintaining things like a hospital formulary. Or should we relook at our funding and insurance model?
Yeah, well, so a lot of healthcare resources are put into creating all of these different lists. Every pharmacy has their own list. Certainly every province has their own list of medications that would be publicly funded for social assistance recipients. Then there are some clinical groups that create their own lists. So lots of time and energy gets put into creating these lists and updating them. What doesn't happen in Canada is that we don't have a national list, and I think people in other countries are really surprised by that. And I'm sometimes in this somewhat embarrassing situation where I'm presenting at like WHO meetings about comparisons of essential medicines lists between countries, and sometimes providing advice about how lists could be changed and how processes could be changed. And they say, oh, maybe we should have a process like Canada's, because Canada has a good healthcare system, right? And I say, well, actually, we don't have a process in Canada. We don't have a national essential medicines list. We just have like 100, 1,000 lists that are out there that nobody knows. External people don't know where to find or how good the list is, or even what the process is. National lists, they tend to be available throughout the entire country. There'll be a public posting of who's on the committee, what is the process for suggesting a change, what's the rationale for every decision that was made, every medication that was added recently, why is it there, every medication that was turned down, what are the specific reasons. We should have that in Canada, and it could really be a benefit to others in a way that the large number of lists we have lying around here are not.
Thank you. A question about deprescribing. Hospital pharmacists or pharmacists in general are useful at appropriate deprescribing in hospital, but not sure there's the same incentive employed by, for example, chain pharmacies in the community. Do you perceive that as a potential barrier to getting people towards an essential list?
Yeah, the problem is with the system, not with pharmacists. In England, community pharmacists play an important role in promoting adherence to the local formularies, and that could certainly happen here in Canada. In the Clean Med study, actually the face of the study was really the clinical and community pharmacists, the dispensing pharmacists, who would help clinicians through the medication changes. And if a clinician would prescribe something that was ineffective or that interacted with another medication, he would gently suggest a change. And in our study, he had access to the electronic health record and could see the rationale for a prescription. And so knew, like, if there was an exception to be made, that there was a valid reason in this case. So I think, we're not realizing the potential benefit of community pharmacists who, because of the way the system is structured, don't really have an incentive to change prescriptions, and are under a lot of pressure for a variety of reasons to work quickly and just fill prescriptions.
Okay, thank you. In the interest of time, I'm going to shorten one of the questions and give you one last question to answer. So the issue was the environmental impact of the drug choices on the list. So I guess it's a suggestion, if you haven't already considered that, for example, the meter dose inhalers. And the final question, are you in favor of outpatient therapeutic substitutions at, for example, a dispensing pharmacy?
Yes, I am. And I'll just say, the environmental impact was actually one of the criteria we used. And I think that's actually one of the huge benefits of essential medicines globally, is that, we have exempted ourselves as healthcare providers from, this climate catastrophe, and just assume that because we're saving lives, we can prescribe whatever we like. But actually, there are a number of examples of medicines that are therapeutically equivalent, like benefits and risks are the same clinically, but one of those agents basically stays in the water forever, or contributes to climate change, and others do not. So, through thoughtful decisions, we could address this climate catastrophe through better selection of medicines, at least partially.
Fantastic. Well, Nav, it was a pleasure to see you and talk to you again. I missed the time we spent in Nanaimo and in Vancouver years ago. An excellent presentation. Thank you so much. To the audience, thank you for taking the time as usual and being so interactive. I think it was a very successful event from my perspective. I wish you all the best of the rest of your day, and Nav, hopefully we'll talk again soon. Take care, everyone.
Thank you all. It's a great discussion.